If you just click on that, वो हो जाएगा. Hello? Hi, Manish. Manish, you're on mute.
Yes.
Ah,
Hello, good evening.
Rachna, you're on mute.
Hello, Manish.
Hello, hi.
Hi. Okay, very good. Let's अपना background set कर दूं. This is better. Hi, Dr. Mona.
Hi, Dr. Rachna. Hello.
Hi.
आप
Hi,
लेटे
Dr.
भी क्यों
Manish.
हो? Very cute, but you're sideways.
Can you hear me?
We
I
can hear
can't
you.
hear you guys.
You're coming sideways. Vijay, any
Me?
thoughts on that? Yeah, you're coming, or is it just me? No? Okay, my bad.
We can see her properly. Yeah.
Oh, okay. Is there something I can do to make her straight? I will check
Is it
on my
better?
side. No, you're good. You're good. That's just me then. Screen. Okay, all right. Vijay, light and background good for everyone? And sound,
Yeah. So
and
far,
sound good. Yeah.
I can hear
Hello,
you.
Raj. I'm just going to adjust my light. I feel like my light is not great. Can you just adjust my light, son?
Nari is asking if you only send this, where is the link to join?
Here.
Afternoon.
Hi, Rajesh.
Hi, Mona. How are you? Long time.
I'm good. Yeah. For 2 decades, so maybe more.
Probably more. Yeah.
Yeah. Good to see you. Yeah.
See you as well. Good to see you indeed. Manish, that was a good picture. We started doing robotics as well.
I couldn't get it.
Hello, Dr. Manish.
Hi everyone.
I don't know if you recognize me.
नहीं ठीक से तो नहीं पहचान पा रहा मैं.
कोई बात नहीं. It's okay. You haven't missed much. ठीक है, anyway. And hi, Vijay.
I think Rachna and Vijay are still on mute.
Hi.
I know.
Okay.
Hi. Wait, unmute. Please let me start my video. Vijay?
Yeah.
Okay, great. Thank you. I was just checking my light. I can do a brief informal intro while we're getting set up. Dr. Mona is our professor's daughter, Manish? Dr. Kulpati?
Yeah.
You remember. Okay. All right. Great. My son is helping with the light. Okay. Thanks. Oops.
And Rajesh and I are batchmates.
Yeah.
From
Since we are talking about background.
Right. Ask Vijay for it. I can't do anything right now. Also, Dr. Neha and I met at Bhagwati Hospital. She is a gynecologist there, amongst many other hospitals in Delhi, Fortis being one, and her own practice, of course.
Hello.
Hi, Vijay, my video is off again.
Hi. हाँ, वो रजिस्टर करने पे आता है. मैं अभी भेज देता हूँ लिंक.
Okay. What are we for time? They've run away with my phone.
Dr. Neha's here.
Dr. Neha.
Hi,
Yeah.
I am here.
Hi, Dr. Neha. Can't see you.
Hi,
Hello.
Hi.
you not see me? Hi.
Yeah.
Yes, I
yeah.
can. Good.
We can see you. We can see you.
Great.
Great. So while we're all here, I will start by just doing a brief intro to the webinar itself and the fact that we've been doing these webinars. And then I would request each one of you turn by turn to introduce yourselves however you want to, through experience, through your current practice, where you are, and maybe a couple of points about the topics that we're going to be speaking about today, just like an overview, and then we'll move to the next person. We'll finish the round of introductions, and then I'll go, as I said, in a question-answer fashion. So ask all of you, give you a little time, each person, to talk about one topic that we have mostly discussed, and then try and weave in as best as I can, pick up something from what one speaker said and link it back to, let's say, another speaker, if that becomes a possibility. So, for example, we had spoken about the questions around HPV vaccine that Dr. Mona gets asked by the parents of adolescent girls, and we link that after she speaks to the pap smear and the importance of the HPV screening. Dr. Neha can speak a little bit about that, amongst other topics. So just hoping to do it that way. And usually, many times, people also have questions throughout the webinar as you're going along. And it's nice to be able to pick those and kind of answer those. It's more interactive that way. So I think and beginning of the year, I hope we do get some good amount of attendees.
All the best to all of us.
Yeah, also remember that we will record this, and our marketing teams can then repurpose some of the recordings and use it in other marketing campaigns. While we're also here, I'd like to announce a couple of things which are coming soon. We will have the ability to book labs with a tie-up with a national chain very soon. We've already gone live with American Express cardholders. I think, how many will be? About 1 million plus or something. You might have seen on the DocGenies landing page. We are revamping the landing page and the website to make it more user-friendly now in the second phase of as we take on more and more work. We'll be onboarding an orthopedic and physiotherapy group. We're getting some other super specialists from the US who want to join and give a little bit of time. So we're going to weave that in as super specialty consults. So exciting stuff from our end, and grateful that all of us are together and going to looking forward.
Absolutely.
Yeah. Vijay, what is the time? Somebody's run up with my phone. So
it's
another 5 minutes to go, but we already have
couple of
people
minutes
joining in. So
you have people joining in. Great. Rajesh, there's something on your screen. I'm sorry, Rajesh, there's something on your screen. Or is it just me? Can everybody see Rajesh clearly, or there's some light shadow? I think the light is striking your screen and giving it some
I can
rainbow.
only see Dr. Rachna.
The camera screen. Now is better.
Now I can see Dr. Manish.
Lost sunlight, so to say, which is over
Dr.
here.
Mona, sorry, there'll be a button up top right saying view, and you should be able to have a view where you can see everybody in smaller boxes, and then the person who speaks appears in a big box. So play around with that if you like. Top right corner for me is view.
Okay.
And you might have clicked speaker view, or Vijay, can you help with that?
Let me do that.
Yeah.
Let me try.
there should be a view button, and you can click on gallery there. So
All right.
Gallery.
Rachna?
Dr. Mona?
Hanji?
Can you see it?
Rachna, I don't have much on this topic, so I'd prefer you better involve me more in question answer form than me saying something about the topic.
Fair enough. We'll do that. Definitely we'll do that. But as you said, that, one topic of hemorrhoids, when Dr. Neha talks about care in pregnancy, I think women are affected by hemorrhoids at that point, you both had said.
Yeah.
So I will link it back to you at that point. And then, you can talk about definitely pregnancy, and then I'll cut it and say, come back a little bit later, because this is a problem in older women as well. And you have many modalities to treat. People shouldn't fear that, once you're going to go in, you're only going to get operated. There are many ways to do an office procedure. Would that work?
Yeah.
Okay, great. So Manish, pregnancy. Yeah, hemorrhoids. Hemorrhoids.
So is there an order you're doing the introductions in, or are we just?
Good question. I was thinking I would just start with Dr. Mona, go to Dr. Neha, ladies first, and then Dr. Manish, and you can be last, Rajesh, since you're a time zone behind us. Are you getting the sun in your eyes, Rajesh?
Right?
You're getting a sun in your eyes.
I'm loving it. I mean, we don't get sun very often, so we are kind of fortunate today.
Yeah, we are getting some London weather here, some cold, grey, foggy weather here. Okay, chat.
We got 4 minutes, haven't we?
We do.
Okay.
We got 4 minutes, so we'll play the video at 5. And give it a few minutes, and then we can start. Yeah. So Rachna, you start at 5 and give us all this thing. And
Okay, so after I start at 5, you play the video?
yeah.
Okay.
Rachna, can I just check one thing? You're not getting any background noise in my room, are you?
Dr. Mona, you are mainly with Rainbow now? You are mute.
Yes. Yeah, Dr. Manish, I am with Rainbow, and I have my own practice also. And of course, I am. That's how I met Dr. Rachna. We're at a place called D-Care as well.
Okay.
Yeah.
Now in Rainbow, most of the doctors I know because they are from Saket only, Max only.
Absolutely. The whole team came, last, a
Yeah.
couple of, I think maybe a year back. The whole Dr. Paul, Dr. Nakra. Yeah.
And even the gynecologist.
Okay. Dr. Shelly or Dr. Jayesh?
No,
Dr.
Dr.
Jayashree.
Jayashree Sundar.
Dr. Jayashree in team, yeah. Correct. So they're the pillars of the gynae work over there. So I don't see anyone now.
Manish, you've got your own robot, or is it at the main facility or some hospital?
No, I am working with Max Super Speciality Hospital. We can't have our own robot. Max, I'm working with Max.
Which one have you got, the XI or the SI?
PXI. Hello.
Do you get to operate on the robot, Rajesh? Yes, you do, right?
No, no. Now I do mostly endourology and robotics is now a chapter of the past. We got 6 dedicated robotic surgeons. We don't need any more.
Okay, great. All right. So it is 5 p.m. Good evening, everyone. That's to all the people who joined us this evening on this cold, wintry evening, and to the panelists. Thank you so much for giving us your time, and we promise to make it as interactive and interesting, clear, and simple the next 45 to 50 minutes as much as possible. I'm Dr. Rachna Kucheria. I'm the co-founder of Doc Ginny Telemedicine. A small team of us and a group of doctors who've gone to medical school together and practiced, all of us are on Doc Ginny. We started the company last year during the lockdown, once the telemedicine guidelines were cleared by the government of India. And we found that patients got great benefit through the last year when it was not very safe to come out and be in large hospital for everyday common problems and sometimes not so common problems. Through video consulting, they could reach doctors from the comfort and safety of their own home and feel at ease. Not only primary care, but many of the specialists that you see here were able to advise them and guide them correctly. We also have been doing webinars, reaching out to people through this medium on a monthly basis. This is our third in the series. The first two we did were centered around COVID and issues around that. And we are glad to note that now in January, we are hopefully turning a corner, at least in this country. The cases are going down, the vaccination drives have started. And so we decided to focus on another large area of medical care, which is women's health. Many questions that get asked regularly and some that maybe women might have some hesitation in asking about. So that's the goal of this webinar today, to be able to talk freely, clearly, simply with people who do this in practice every day, follow the science, and to be able to give you some good, correct answers to your questions. I'm so happy to introduce our panel, which I will in just a few minutes. But while we're waiting for other participants to join, it's just a little bit over 5 p.m. Take a look at this video that we've put together about the specialists and about who we are.
एक बार आना.
Is it just me or there's audio issues?
Hey everyone, I'm Dr.
Please bear with us. Can we restart the video, please?
Yeah, it's audible.
Now it's audible. Thank you.
Dr. Neha Jain. I'm a consultant gynecologist and obstetrician and infertility specialist. I'm also an endoscopic surgeon. an experience of 15 years in my field. I'm treating mostly diseases like fibroid, PCOD, ovarian cyst, bulky uterus adenomyosis, and I believe very much in natural vaginal delivery as compared to cesarean section for my obstetric patients. I'm dealing with all kind of high-risk pregnancies.
Hey everyone, I'm Dr. Mona Kulpati and I am a practicing child specialist. I have been trained in the country and the UK, and I've had the pleasure of working at the All India Institute of Medical Sciences, New Delhi. It's been a journey of nearly 2 decades and a very joyous one treating children. In my day-to-day practice, I treat conditions like fever, cough, cold, pain abdomen, vomiting, diarrhea, constipation, growth faltering, and many allergic manifestations. Just to conclude, the most important domains of child health care, which is the right of every child, are 1, breastfeeding and optimum early nutrition. The second being periodic growth monitoring and developmental assessment. And lastly, optimum and up-to-date immunization.
Hi, I'm Dr. Rachna Kucheria. I'm a family physician with over 27 years of experience in India and in the United States. I treat all kinds of ailments, from flu, fever, coughs, to diabetes, blood pressure, high cholesterol, as well as mental health problems like depression, anxiety, panic attacks. During my years of practice, I've had a special focus and passion for looking after the elderly, especially the older elderly over 85.
Hello, my name is Rajesh Kucheria. I'm a practicing consultant urologist in London. I have been a consultant now for 8 years. My background is that I come from Delhi, but I have graduated in India and now done my surgical training and urology training in London. My main specialty interests are recurrent urinary tract infections, managing kidney stones, prostate problems, bladder dysfunction, and kidney issues. Hope I can answer your questions and also help in any way I can.
Thank you for that, Team Dr. So, good evening. Without further ado, since the introduction was wonderful on the video, I would like to request, I think we'll start in the chronology of just the human life. We'll start with our pediatrician, Dr. Mona Kulpati. I'd like to please invite her to say a few lines about herself, and then perhaps let us know some of the topics that she will be touching upon this evening. And then we'll move on to Dr. Neha, Dr. Manish, and Dr. Rajesh. So over to you all.
So thank you, Dr. Rachna. Thank you so much for having me on the webinar. And it makes me really happy that Doc Genie has chosen women's health as their first topic for their webinar of the year 2021. So a very happy new year to all of you out there who joined in, and of course, my fellow panelists out there. To start off the conversation on women's health, well, as a girl kind of, transitions from childhood to early adulthood, she goes through a phase of adolescence. I mean, which is say about 8 to 19 years of age. And this is a phase of rapid growth and a lot of changes. So when we talk of changes, it means not only physical and bodily changes, but also mental and emotional changes. So at the offset, what I, as caregivers, as doctors, as parents and teachers, what I'd like to kind of so for to educate our girls about the physical or the bodily changes that are expected to happen in them. So, when a girl is kind of getting into her adolescence and sees the pubertal changes, her breast size changing, hair popping up, in the underarms and the private areas, and of course, the onset of the menstrual cycle, which is the menarche, it can be quite overwhelming for the girl child. And of course, subsequently, things about the sex education and sex identity. There can be many concerns that a girl child can face about her changing body. So when I say about education, it is just to make the girl child more comfortable and very confident with what to expect that is going to happen with her. Whether it's about the blood flowing, is it the flow is heavy or is it less flow? Is just the dysmenorrhea, which can be very challenging for early part of the menarche, or it's like making a choice between what she wants to use. Talking to her mother about whether she wants to use sanitary pads, tampons. There's a whole lot of choices, vaginal cups. So all these things are very important to be talked about and a girl child to be educated about.
Wonderful.
Of course, yeah.
Good.
Yeah, of course. Besides that, a quick note on sex education, which is very important on my mind. Girl child has to be educated about her choices. What is consent? What is contraception? What are the choices of contraception, conception, and unwanted pregnancies? These are not things which we read in books. These are actual issues which are to be communicated and told our girls about. And the whole concept of making a choice of what she wants to do and how she wants to do. So yeah, whatever.
Wonderful. I'm thinking, Dr. Mona, these are topics that we could have an entire webinar on. So I'm so glad that by at least touching upon these, and I would request that this is very participatory, that our panelists do write into us. We take your comments and questions and requests very seriously, and that helps us build the next set of webinars that we conduct. So all very, very key issues that I'm sure parents, young women, young girls would like to ask about. Thank you so much. So we'll be touching upon many of these in the next hour, I hope. So I'm moving on to you, Dr. Neha. So the young girl is now a young woman, maybe even an older woman, and that's where you come in, Dr. Neha.
So hi, I'm Dr. Neha Jain, and it's a great initiative by Doc Jenny, as women's health is a very important concern for all of us. So basically today I'll be discussing about human papilloma virus, HPV, which is a causative agent for cervical cancer. And you believe it or not, cervical cancer is a preventable cancer. It can be prevented if we know about human papilloma virus, its pathology, how to control it, how to avoid the risk. So first of all, we'll be discussing about HPV. Then my next topic of discussion would be PCOD, the commonest hot topic these days amongst young girls, adolescent girls. The name is big, PCOD, polycystic ovarian disease, but nothing to worry, nothing to freak about. The mechanism of the disease I would like to explain so that all young girls can take specific measures and lifestyle changes to avoid such a problem. Then third is definitely being a gynecologist and obstetrician, I would like to discuss about antenatal checkup, the 3 trimesters of pregnancy. So these are the 3 topics which I'll be discussing today. So that's
wonderful. Wonderful, Dr. Neha. Again, with each of your specialties, we could have fill many webinars with even just one topic, but hoping to address at least the most important common concerns that see in your practice every day, that people ask questions about, that there are common myths surrounding. So really look forward to getting some of those questions answered with you. Excellent few, top of the mind topics you've picked up. Coming to you, Dr. Manish, as a surgeon, sometimes women may be concerned, Dr. Manish ke paas pahunche, surgery ho jayegi. But I know as your colleague for many years, and you're one of my go-to people for all problems surgical, that you really take your time before you commit somebody to surgery. And that is one reason why I have the confidence of sending people to you. And with respect to today's topic, I think we talked about piles, issues around the anal area, where we pass stool from. Not a comfortable topic for women generally to bring up, as I find in my own practice. And it could be younger women in their years of pregnancy, or it could be older women, who are post-menopausal. It's a private issue that they may deal with every day, when they go past stool, many different problems. So coming to you, would love to hear about what you're going to tackle today. But I know I took up some of your topics because this is what I deal with also as a family physician and as a woman family physician. Muted. Dr. Manish, please unmute yourself.
Thank you, Dr. Rachna, for giving me an opportunity. I'll just introduce myself. I am a surgeon. I am Associate Director in the Department of General Surgery and Robotics at Max Super Specialty Hospital. Now also associated with Doc Genie for online consultations. So today I will limit myself to certain diseases which get aggravated during and after pregnancy, especially related to hemorrhoids. And a very important topic is the breast abscesses or breast problems which patients develop post delivery. My discussion will be limited to how to prevent these or to keep them under control when you have these diseases at a subclinical level and they get aggravated during pregnancy. So how to keep it under control and to prevent surgery. And even if a surgery is required, how to get through the pregnancy safely.
Excellent, again, choice of topics. I love that you included breast abscesses, which if dealt with early, not such a big problem. It's basically simply put an infection in the breast, rightly said. But if left till later, the management is so painful and so laborious. So I'm so glad that you're going to touch upon that topic today. Last but not the least, I have the pleasure of inviting a family member, my brother, Dr. Rajesh Kucheria, who is joining us from London, so a few hours ahead of us, behind us in time. And over to you, Rajesh. I will just use that as the introduction.
Thank you, Rachna, and thank you, Doc Genie, for giving me this opportunity for coming across from London. As Rachna said, that I'm one of the urologists here and been practicing urology after training in India initially. I'm going to touch upon the two main topics which I see patients of in my clinic, which is urinary tract infections, especially the recurrent urinary tract infections, and also touch upon incontinence. In between these topics, there are lots of overlapping and other issues, things like when patients have asymptomatic, bacteria in the urine or have symptoms of infection, but every time they get a culture done, there is no infection. So it's a challenge for treatment for both the physician and probably a bigger challenge for the patients to get treatment. So I'll be touching on these topics and be happy to answer these questions. And once again, thank you, Doc Genie, for giving me the opportunity to speak about it.
Of course, and I will take that extra line since you didn't expand upon your own accomplishments. So Dr. Rajesh is a practicing urologist at the Royal Free Hospital in London. And right now, of course, volunteering like all the doctors here, they're in a bad shape with COVID. And he has a private practice as well, where he deals with multiple urology issues that he just spoke about. He is on our panel and available very soon for second opinions. So with that, let's get going. Dr. Mona, would you like to talk about a little bit about what you touched upon, the girl child and normal changes that they undergo, and perhaps with that also weave in a little bit about the HPV vaccine and questions that girls and mothers may have?
Absolutely, Dr. Rachna. So coming to the issues with the girl child, we've talked about the bodily changes. But what is also often left aside is, the mental and the emotional changes which a girl child goes through during her adolescence, and obviously as she is progressing into adulthood. So some of the concerns which I see in my daily practice are very overt, like, study pressure, peer pressure, anger, defiance, and so on and so forth. But there are also some very covert, non-talked about issues, as in isolation, depression, sexual identity issues, sexual debut issues. So these are also things which are, kind of make the backbone of a girl child's health. So for the mental or the emotional issues, I would say as caregivers, it's very important for us to listen to our girls. So half the, I think, battle is won when we're listening to them as parents or as doctors, either which way. So that is one thing which is, I think, is very important. I'm very happy that both you and Dr. Neha have asked about HPV, which is the human papilloma virus. So I'll just quickly make about 5-10 lines on it. So the HPV, there are about 100 odd genotypes of the human papilloma virus. But it's the more high-risk ones, variants, as in the type 16 and the 18, which causes cervical cancer in women. So why I want to talk about this is, and take this opportunity, is because cervical cancer is the second most commonest cancer in women after breast cancer, one. The second point being that 25%, 1/4 of the burden of global cervical cancer burden is carried by India itself. And as Dr. Neha mentioned, not only if it's timely detected, it can be well treated, and it's also curable cancer. So it's very important to understand the importance of not only vaccinating our girls with the HPV vaccine, but also regularly doing a pap smear, or as we call it, screening for cervical cancer. So having said that, just maybe a quick note on why is HPV or cause cervical cancer so high in our population. So I would say vaccine and doing a pap smear. So that is about it. I mean, there's of course a whole schedule about, I can go on and on about the HPV vaccine, but I'll maybe let Dr. Neha take it forward. Yeah.
Dr. Neha is going to tackle about the pap smear as well.
Yes.
One question before we move to Dr. Neha is that since the vaccine is, the schedule starts, in the early years, which is the girls probably coming to you, what questions do mothers have? What sort of resistance do you get when you offer the HPV vaccine? What do you have to counsel the mothers of the young child when they say that, and especially in the Indian society where, dating is not a common thing, still, what are some of the answers you give? And
so Dr. Rachna, the WHO and the ACVIP, which is the Advisory Committee for Vaccines and Immunization Practices, recommends that HPV vaccine be given to girls from 9 to 14 years of age. And of course, there's a different vaccination schedule pattern for those who are given at 9 to 14 and those who are given 15 and above. That is another topic altogether. But what we need to understand is that why parents do come up with questions that why so early? Why do we need to vaccinate our girls at 9 to 11 years or 9 to 14 years of age? So that is not to say that we are encouraging girls to get into sexual debut or to kind of promote any Western culture. The point is to understand the global burden and the burden in our country. The point is to understand that prevention is better than cure. And what is to understand is that why is it given at 9 to 14 years of age is because the immune response is highest at 9 to 11 years of age, one. The other thing, that if we give a good coverage to our girls, which is say more than 80%, then we're also giving herd protection to our boys, right? And it's also a logistics issue that when we give the vaccine as early as 9 to 14 years of age, it involves only 2 doses, which is a fairly cost-effective way of immunizing our girls along with the other adolescent vaccinations, vis-a-vis giving 3 doses. So this is something we need to talk about more and let our parents understand that this is nothing to do with emulating the Western culture or to kind of encourage early sexual activity, but it is to understand that this is what we are facing, this is treatable, and we need to address it with our teachers, with our girls, and with our parents as well. Yeah.
Wonderful. Wonderful. I'm just going to reiterate the 3 points before I come to Dr. Neha. I think that's excellent you made those points. And I think in general, the population is now much more educated about these terms of vaccination and herd immunity. The first being that, you know, in this age group, because they're young, their immune response is robust. So the immune response is great, they make the antibodies, and that's one reason to give it in the younger age group. The second, you said that eventually, you know, when girls do become sexually active at the right age, right time for them and their family, then there is protection to the men they are with. There's a herd immunity happening because, you know, they are immune to pass the virus around. And the third thing you said, logistics issue, that, you know, later, the later schedule has more doses. In the younger years, you're done with 2 doses. I also would like to add that it's perhaps a captive audience. It's easier to do it, you know, in a school-going adolescent population than when people are adults and have many things to do. So excellent points on HPV, which takes me right to Dr. Neha and her practice of actually seeing the problems that arise and how, you know, all our worlds change. You use a very important term, preventable cancer, Dr. Neha. So preventable cancer is, you know, just such a term that gives such relief when you hear it. Over to you and your experience with HPV, pap smear, and this preventable cancer, which also came to us later in our medical careers.
Yeah. So Dr. Mona has highlighted very relevant points regarding HPV vaccine. Basically, HPV, human papilloma virus, is being harbored by males as well as females. And it is a very common virus. It is seen in majority of the population. The virus is transmitted through sexual transmission. The mode of transmission is basically through sexual transmission. So basically, why we give vaccine so early, as what Dr. Mona said, all those points, and also because as if the vaccine is given before the sexual activity, then the relevance of the vaccine is much more if we give it after the sexual activity. So it should be given as early as possible. Earlier, the better it is, more effective it is. See, there are many kinds of human papilloma viruses and like almost 100 varieties, but the high-risk ones are like HPV 16, HPV 18. So if we are able to curb these infections, then we are able to prevent cervical cancer. Cervical cancer is mainly caused due to these 2 viruses, these 2 types of the HPV. So that's why this vaccine is suggestible. And if we come to investigation, definitely we can detect HPV and cervical cancer changes early. If we start doing pap smear, a test known as pap smear, you must have heard about it. Or if not, then I'd like to tell you that it is a very important test. And it should be done in all sexually active females every 3 yearly. Every 3 yearly it should be done. In this, we take a specimen from the mouth of the uterus, that is cervix. We are talking about cervical cancer. Cervix is the mouth of the uterus. So we take a smear from the mouth of the uterus, from the cervix, we put it on a slide, and then we watch it through a microscope. And in microscope, we are able to see certain changes in the cervical cells. And those changes can tell us that are they cancerous or not. And that is how we can even treat it through measures like electrocautery, through cryocautery, through leap biopsy, through punch biopsy. We can literally remove those lesions, you know. So if we detect it at the right time.
Sorry, I'm just going to stop you here. very nicely put. I'm just going to interrupt you here. When we say cryocautery, freezing cautery, or leaf biopsy, basically we are saying that the bachedani ka move, that cervix area, you can freeze it, you can burn it, you can take out a piece of that bad-looking cancerous area, is what you're saying, right, Dr. Neha?
Yeah, even they are not bad, when we look at them grossly. So that is why we have to look at them microscopically, and that is through pap smear or liquid-based cytology. I would say liquid-based cytology is much more sensitive, but in a country like ours, even pap smear would do the needful. Then we also take a specimen for human papilloma virus, and we send it, and it is a very strongly suggestive test. If it is positive, if type 16 and type 18 are positive, then we can really take some special measures to curb the cancer. If HPV is positive, so that doesn't mean that the female will have the cancer right away. HPV turning into a cancer takes almost 10 to 20 years. And that's why we need vaccine very early. Because once a girl will get the HPV infection, she will not get the cancer right away. She'll get it after 10 to 20 years. So prior to 10 to 20 years, we are able to catch it and to treat it. So that is what the beauty of science is. But the problem is health education. And I am just proud to be part of Doc Jenny, that through this medium, we are able to spread, this information. At least we can do our part. So
wonderful.
Hopefully you find it in.
Wonderful. No, I have excellently explained, Dr. Neha. Just to recapitulate what you said, that basically it takes some years once you get the virus, HPV, human papilloma, to turn into the cancer. And so the earlier you vaccinate, you probably won't get the virus. And then keep doing the pap smear check, which is very simple, going into the office of a gynecologist like Dr. Neha, I'm sorry, and getting a 20 minutes and out home, you drive yourself home or you take the public transport. It's really simple, done every 3 years, and no woman should go without it. There are a couple of questions from the audience, which I'll take right here since we're on the topic. There are questions on the age of the vaccine, and either Dr. Mona or Neha can take it. Somebody has asked, can we get it at 32? Somebody has asked, can we take it at 20? So would one of you like to take the question on the outer...
Yes, so maybe Dr. Neha can add on. So to my understanding, there are two vaccines available in the country currently, so which are for girls, say 19 to 19 years of age, and the dosage is different depending upon whether we are giving at between 9 to 14 or 15 and thereafter. However, there is another vaccine, a non-valent vaccine, which covers additionally, besides the quadrivalent, 5 more variants, strains, and that can be given up to 45 years of age. Am I right, Dr. Neha? Would you want to add to that?
Yeah, you're very much right. It can be taken at 32 years of age, but definitely earlier the better it is.
Absolutely.
Okay, great. All right. So I will shift gears a little bit, since we're going to, we'll tackle with pregnancy and normal pregnancy in a little bit. But in the meantime, why don't I come to Dr. Manish to talk about the breast abscess issue that you spoke about, Dr. Manish, and we'll come to hemorrhoids after Dr. Neha talks about normal pregnancy and care. But let's talk about breast abscess and how to prevent and how to treat it in its early.
Abscess, in a layman term, is something when the pregnant women after delivery, during breastfeeding, if the breast milk extraction is not normal, the mixed milk collects inside the breast and forms a swelling or a lump. And if it gets infected, it becomes very painful. This is what a breast abscess is. And it is a disease which is normally a postpartum female will say that I have started developing a lump in the breast, which is painful, and she reaches the gynecologist. Now, the first what I will discuss is what should a patient or what should a person do during pregnancy to prevent breast abscess. If a person has any history of a lump in the breast or a past history of a breast abscess like in the previous pregnancy, they should consult the gynecologist, and if advised by the gynecologist, they should meet a surgeon before they plan the second pregnancy. If there is a lump, or if there is a disease in the breast, or if there is a distortion of the nipple, it has to be dealt before pregnancy, as during pregnancy it becomes impossible to deal these conditions. And if these are dealt before pregnancy, then usually they don't form an abscess. Secondly, the patient has to be tutored nicely about breastfeeding. If the person keeps on expressing out the milk regularly, chances of forming a breast abscess reduces significantly. If there is a collection, at times we have to give antibiotics at an early stage from preventing to reach a stage where a surgical intervention is required. So, but once it forms and a course of antibiotic is not effective, we can do a small surgical procedure, and in most of the patient can continue with breastfeeding even after a surgical intervention. Yeah, Rachna.
Wonderful. Great. A very, very important topic, as you said. I think this is really to note that if a woman has any sort of abnormality in the breast, women know that, then of course you're consulting your gynecologist. But before that pregnancy is planned, if it's a planned pregnancy and you have that abnormality, see the surgeon, make sure that things are okay and you don't land up in trouble after the pregnancy, when there is going to be milk production in that breast, and then things are quite difficult through and after the pregnancy to take care of. So very, very important. And if any of us have,
I'll just like to add, at times the baby is not able to suckle properly for the expression of the milk. So at that time, the gynecologist explains the patient, or the patient has to find ways of expressing out milk, which is very difficult doing manually. The use of breast pumps or use of right breast pumps helps in regular decompression of the breast and prevent such diseases.
Very, very important. I think in all our practices, if you've seen a woman suffer with the breast abscess, go through the surgery and then go through those dressings, it's so painful and something that could have been prevented. So just the take-home point is that the lactating mother should be lactating well, whether it's the baby sucking on it or you're using a breast pump. That breast milk should not stay back inside, because that it will become a problem very soon, or sooner or later. So that's the take-home message from that. Excellent that you brought it up, Dr. Manish. Coming to you, Dr. Rajesh. Let's talk about a very, very common problem, urinary tract infection, or UTI, as you and I speak about in our language. I think most women, I'll leave you with the statistics, but I think that most women suffer with that, or at least a few episodes in their lifetime. So a very common thing, and certainly something that I get called for by a lot of my women patients. And of course, when we get to the complicated sections, which we can of course talk about later, then I need to consult people like you. But let's talk about UTI and hear what you have to say from your years of experience.
Yeah, thank you. So urinary tract infections, as you mentioned, that's a very broad term, which means any infection in the urinary tract. And the urinary tract starts from the kidney and ends at the end of the water pipe or the urethra. And in women, there is kidneys and the bladder, which are the main issues. In men, there are a few other things like prostate and the genitalia. So focusing on women, how common is it? And you're absolutely right. I think every woman gets at least one episode of cystitis or bladder infection in their lifetime. And around 12 to 20% of these women will then end up having recurrent infections. And what we mean by recurrent infections is at least 2 infections in 6 months, or more than 3 infections in a year. And that sometimes becomes a challenging problem for physicians, even for urologists and gynecologists, because these patients do suffer these symptoms quite repeatedly. And they feel there is no end to it, because every time they have an episode of infection, they get a course of antibiotics. It settles down. A few weeks later, again, it happens. And it's a fairly big problem from that perspective. So I wanted to sort of say a few things about infections. Don't just need to be treated by antibiotics. just like HPV and cervical cancer, there are preventable things we can do, focusing on sort of, a good assessment of the patient with not just the symptoms and the sort of issues around infections, but also about their lifestyle. Because almost a fifth of women will find that just by changing some of the things in their lifestyle can prevent recurrent infections and improve their bladder defenses and immunity. So that's what I tend to focus on. I tend to sort of try and treat patients without medication initially. If obviously not possible, then we move on to antibiotics. Then there's also a whole thing about what we call antibiotic stewardship, or being sensible with antibiotics. You need to be sort of careful what antibiotics you use, how long do you use. There comes the importance of cultures of urine, because in India, especially now, there is a lot of antimicrobial resistance and resistance to antibiotics, as antibiotics been used and overused, in my opinion, sometimes in certain parts of the country. There are other options of treatment as well. Some of them are not purely surgical, but where we need to intervene, where we might have to sort of do things like invasive investigations, like putting cameras in the bladder, or what we call cystoscopies. There are other chemicals we use, and I'll explain that in detail a little bit later on as to how they work and how do you improve the defenses within the bladder. First and the most important thing, in my opinion, is hydration. As we are all getting sort of busy in life, and it's more fashionable to hold a cup of coffee in your hand than a bottle of water, it's issues that you get inflammation. And inflammation in the urinary tract is the precursor or the first step for recurrent infections. Because with inflammation, your normal defenses of the tissue in the bladder lining, in the kidneys, they tend to become weak. And when they become weak, that's where bacteria get in, and then bacteria cause more inflammation. And that cycle of inflammation, infection keeps going on. And to break that down, you have to treat inflammation along with the infection, or treat inflammation once the infection is gone.
Excellent point. Going to interrupt you for a second. If you can sort of differentiate inflammation and infection for our audience, that would be great in simple layperson terms.
So infection is basically a bacteria invading tissue in your body, and infection causes inflammation. Inflammation is the body's response to that infection. If you see sort of what we call general signs of inflammation, especially when there is a generalized infection, you get things like temperature or fever, you get pain, you get swelling, you get red color of the tissue or inflammation. So in bladder, the inflammation and the infection have exactly the same symptoms of burning when you pass urine, you get pain after passing urine, you get urge and frequency to pass urine. So it's very difficult to differentiate these symptoms of inflammation and infection. They're more or less the
And do
same.
you do that urine test?
But yeah, so infection is picked up on laboratory tests, like either urine being checked with just a chemical stick, what we call dipstick, or actually the urine being sent off to a laboratory for a culture. The second one, the culture, is more important from a physician and a urologist point of view, because that helps us in directing to what antibiotic treatment is necessary and what bacteria is being seen inside.
Right. Excellent points. And I do like your point about that you made a very interesting point about preventing UTIs and making lifestyle changes, holding that refillable bottle of water and not a plastic one, and not the cup of coffee. Any other points you'd like to make? We'll come back to UTI and some other complications in a little bit, but any other points on that lifestyle part that you were hinting on, besides drinking the water, things that women can do to sort of, prevent UTIs, if you may, or myths that can be busted, that if you do washes and things. That
the important thing is to differentiate UTI into sort of, age groups, because you see two peak incidents of UTI. One is the young adolescent to sort of late teen women who's just starting her sexual life, and their main trigger being sexual activity or intercourse. And the second peak we see is postmenopausal women, because they are becoming de-estrogenized. In other words, their estrogen levels are going down, which also has a defense or a sort of a preventing factor in the introitus, or the area around the vagina and the opening of the urethra. Lifestyle changes. There are very simple, they've been kind of evidence-based now. Hydration and regular voiding. Why does that work? Because if your urine is dilute, you will have less irritation to the lining of the bladder. So inflammation comes down. Simple thing. Similarly, regular voiding, passing urine regularly, not holding back, especially, school-going girls tend to sort of prolong their voiding because maybe the toilets in the school are not very hygienic, or classes, and they don't get a chance. So it's embarrassing going to sort of the toilet again and again. But that prolonged voiding creates, again, inflammation. And if there are any bacteria in and around, you are basically prolonging, and that becomes a habit over life. And mostly people or young girls who've been prolonging voiding or not passing urine regularly tend to end up and having more problems with recurrent infections in later life. So you start sort of pretty early. Regular voiding, hydration, using of things like soaps down below is not very good because it creates inflammation. It wipes away your natural defenses. There is an acidic fluid which the vagina creates. It's a natural defense. So if you're overly hygienic as well, it's not great. So you have to get a balance between those things. Coming to older women, slightly older women, the 20-year-olds, the 30-year-olds.
I'm going to come back to you, Dr. Rajesh. Hold that thought. I'm going to circle back to you in just a little bit. But I'm going to bring in Dr. Mona here, since we talked about the young girls and urinary infections and holding. Although Dr. Mona, urinary infection is quite rare in children, and I will come to the girl child here, it does happen. And when should a parent be concerned if a child is complaining while passing urine? If you could touch upon this topic, since we're on it, and perhaps you see it as well, as to some words of advice for parents of young girls around this.
Yeah, Dr. Rachna. So actually, urine infection is not so uncommon in children, not even in newborns. So the only thing is that the route of spread is hematogenous in newborn children. And as the child gets older, the UTI is because of direct routes. So like Dr. Rajesh was mentioning, there are a couple of preventive measures that we can, as parents or caregivers, take to kind of avoid urine infection. So one is like there are conditions like constipation, pinworm infection. These can be addressed, and we can kind of reduce the possibility of having UTIs. And of course, frequent diaper changes, making the child toilet trained and to urinate frequently, that would help. To answer your question that how would a child present with a urine infection? Well, it can be kind of, sometimes it's overt in the usual forms of developing fever, unexplained fever, or fever over three days with burning while micturating, or urgency, or just passing urine quite frequently, redness around the urethral orifice. However, in children, sometimes, especially in the newborn children, it can be fairly, disguised in the form of just poor feeding, or a lethargic baby, or a child with prolonged jaundice. So it requires a fair amount of clinical suspicion in the absence of fever to think of UTI in newborns as well. So it's not so uncommon, neither in the newborns or younger children. Yes.
Yeah, great. Yes, so parents should be on the lookout for that as well. And your pediatrician will know, Dr. Kulpati is experienced, but your pediatrician will know what tests are required, or if they're required at all, if to give antibiotics or not at all. Those are very important decisions in this young age. I'll come to Dr. Neha, and let's shift gears, and Dr. Neha get into the pregnancy mode, which your practice is divided into two, and obstetrics and gynecology. So I'll let you take it away from here about pregnancy care, any vaccinations there, normal versus cesarean delivery, the very common top of the mind questions that I usually asked.
So basically, I will say that we'll divide pregnancy of 9 months into 3 trimesters. like the first trimester, first 3 months, then mid trimester, that is second trimester, from middle 3 months, and the third trimester, that is last 3 months of the pregnancy. So in the first trimester, as the baby is forming inside the womb of the mother, so this trimester is very crucial for the growth of the baby, for the development of the baby. All organs of baby are being formed in this trimester. The baby is being formed. So in the first trimester, we generally suggest methyl folate to mothers. It is a vitamin, and it is a water-soluble vitamin. So even if it is extra in the body, it washes out with urine. So we suggest methyl folate. Now, generally, you must have heard about folic acid. Most of the ladies must have heard about folic acid, but we prefer methyl folate as it is an active form of folic acid. And mostly Indian women are deficient in the enzyme, which converts folic acid into its active form. So that's why the preference is towards methyl folate. So this is the most important prenatal and first trimester vitamin, which we suggest. Then according to the other symptoms of women, we suggest other medicines. But as far as symptoms are concerned, in the first trimester, most women complain of excessive nausea and vomiting. Now, this is, we also name it as hyperosmia. This mainly affects due to the hormonal imbalance in the body, I would say. But rather than going much into the etiology, I will like to suggest that how these symptoms can be decreased in pregnant women. So first of all, in case of any such symptom of nausea and vomiting, it will be great if you visit your obstetrician, as she will suggest you some important medications which are harmless for the children. Generally, in the first trimester, we are very judicious in giving medicines because as I told you that the baby is being formed, so that's why we have to give medicines which does not cause any congenital birth defect in the baby. So that is how we suggest relevant medicines. We ask you to avoid any, spicy food, junk food, and definitely you should avoid Chinese food also, as it has Ajinomoto, and that is, that can cause some birth defects in the babies. Caffeine, coffee should be avoided. Tea should be avoided, and these are the main things. Also, papaya and pineapple is to be avoided in the first trimester of pregnancy, along with the jerky journey. But if you see other things that you can really move around, you can do your job, you can continue with your work, your routine activities can be carried upon. There is nothing like that you should, take, you should lie down on the bed and take just unnecessary, rest on. It's just not recommended from our side.
Wonderful. Sorry, go ahead. Yeah.
Then in the first trimester, we suggest an ultrasound. Now that ultrasound is very important as we see the heartbeat of the baby in the first ultrasound. And it is also important for finding out the correct dates of the baby, so that later on we are able to know that what is the exact date of the delivery, etc. So in the first trimester, we look for the heartbeat of the baby, and definitely ultrasound is not at all harmful for the baby as it does not carry any harmful radiations. So
Wonderful.
that myth should be broken.
Excellent points. I'm going to come back to you, Dr. Neha, in the interest of time, but you made some excellent points about the correct vitamin to be taken in the first trimester, why the methyl folate is important, and the fact that the ultrasound is essential, no harm caused, and to keep any medication almost to a zero because this is the time that the baby is being formed. We will come back to you. I see that we're getting close to 6 p.m. How time flies. Let me bring in Dr. Manish here, since we touched on pregnancy and you've taken it very nicely. As I said, each of these topics could be a webinar in itself, but because in the interest of time, we'll touch upon a few things. Dr. Manish, one of the problems during this time, as you yourself have said, is the problem of piles, hemorrhoids. Having you take it away from here.
So the aim is to enjoy your pregnancy and the child after delivery. So anyone having any rectal issues, when I say rectal issues, means any discomfort, pain, bleeding in your anal passage, we can't let that get out of hand during pregnancy. First, I will tell you a certain simple preventive measures before pregnancy, which you can do to have a nice, peaceful pregnancy. Anyone who is having any problem with constipation or a history of pain or bleeding in your stools have to be careful and have to change their lifestyle before pregnancy. When I say change your lifestyle, I mean that you have to develop a habit of passing stools at the same time daily. It's a very common problem we see today now because people are on shift duties, they have night duties, they have tense jobs. So if we can avoid constipation, and to avoid constipation, if we can develop a habit of passing stools daily morning, that goes a long way in preventing these diseases. The second is to include more fibers and water to your diet. A very important advice in today's world is to sit in the toilet seat for the minimum or the required amount of time only. It has become a habit. It's a me time in the bathroom. You go with your laptop, you go with your iPad, and then do your WhatsApp and mails in the sitting on the toilet seat. That is very, very detrimental. So anyone who has pain or bleeding in a normal life should consult a surgeon, maybe the gynecologist, and get treatment for it before you get pregnant, because these diseases tend to get aggravated during the second trimester of the pregnancy. That is the time when the child has grown in size and the uterus is pressing on your veins in your stomach, which causes more engorgement in the rectal area, more chances of the disease getting out of hand. In young people, that means people who are planning pregnancy, we have many non-operative treatment for controlling piles so that you can get through the pregnancy without any problems. We have infrared coagulation, we have cryotherapy, we have laser surgery, all are outpatient procedures. You come to the clinic, get it done, and you can walk back home. And these small 15-minute procedures can get your pregnancy safely out. The second thing is, if these precautions are not taken and these diseases increase during pregnancy, we are stuck. We are not able to give you any anesthesia. We can't do any surgeries. Hemoglobin during pregnancy is otherwise also a challenge. And if you keep on bleeding, then also it becomes a problem. There are certain procedures which we can also do during any stage of pregnancy, like infrared coagulation and sclerotherapy and banding. So these are again outpatient procedures we can manage and we can do it.
Right.
Basically,
Right.
I say we have to train ourselves like we train our dogs, that daily morning we have to develop a habit, like certain people have a habit of reading a newspaper or having a cup of tea, or you have a nimbu pani, a thing which you can do every day regularly. And that should be an initiating factor for you to have a pressure to pass stools. So that habit has to be developed, especially people who are prone to constipation. There are certain medicines which you can take without any advice from the doctor, like Sat Isabgol, which comes into many trade names. That is something, just a plate of salad, nothing more than that. Having it before sleep, that means 8 hours. It is effective after 8 hours of having it. So if you are in a habit of going to the toilet in the morning, so you have it before going to bed, the pressure and the passing of stool will be normal in the morning. These simple precautions can make your pregnancy much more comfortable.
Wonderful. So Isabgol, water, simple things, advice that even the senior members at home will give you. But the simplest things can be sometimes the best and most effective. As all of you have said here, that prevention is better than cure, and giving great tips on that. We are coming to 6 o'clock. We have some questions on menopause, on other issues around hormones and acne. I don't think we can take all of them, but we will plan further webinars on that. I would like to, in closing, I would have liked to do let us know, Dr. Ginny, if we have about 10-15 more minutes, then I'd like to at least address with Dr. Neha, come back to an important topic, PCOD, that she deals with, perhaps, and then maybe a couple more lines on a little bit of, maybe menopause, and then tag on to Dr. Rajesh about the UTI in menopausal women. So we cover all the age groups. So let's try and cover these 3 topics if we can in the next 10 minutes, I think, and then we will have to stop somewhere. So Dr. Neha, over to you for PCOD and perhaps a couple of points on menopause. One of the attendees has asked a question.
Okay. So PCOD is a commonest hormonal disbalance being faced by adolescent and reproductive age group women these days. It's commonly seen in 20 to 30% of the girls who visit our OPDs. So 20 to 30%, it's quite a lot. So basically what happens is that few girls have a tendency to develop hormone disbalance when they gain weight. Like, whenever they gain weight, so there is a kind of a hormonal imbalance, which results in symptoms like acne, hirsutism, that is hair growth, most importantly, menstrual irregularities. Now in PCOS, the menstrual irregularities are mainly like either they may have irregular periods, like scanty periods, or delayed cycles, girls not having periods for like 2 months, for 3 months, even later than that. So that's what the problem in the PCOD is. So if you get any of these symptoms, then nothing to worry about. Just visit your doctor, and your doctor will suggest some blood tests to you and an ultrasound. If an ultrasound, you will be able to see some cysts in the ovaries, small cysts. Now those cysts are not a matter of concern. The main concern is the hormonal disbalance. So your blood test will also suggest us some disbalance.
Great. As you said that if then the young girls are overweight, then perhaps again that lifestyle issue of looking into the weight issues would be an important one, right?
Yeah, right.
Excellent. I will just look at this question that I have over here. Any guidance with dealing on menopause? Now that's something I also do as a family physician, and I know you do as well, Dr. Neha. And mostly we try to deal with the symptoms not using any hormones, although they are there. There is hormone replacement therapy, but we try as far as possible to deal with some of the symptoms with using natural supplements if we can. And then only for those with very severe symptoms, perhaps think of very, very low dose hormone replacement. Of course, making sure that now the risk factors for cancer are in place. Am I right? And would you like to add anything to that, Dr. Neha?
Yeah, mostly I would like to say that obesity should be avoided at this age group also, and exercise should be added in your daily regime. As far as food is concerned, then definitely it should be a low-fat diet, and add protein in your diet. And also at this age, as bones start demineralizing, like calcium starts demineralizing from bones, so women should add calcium in their diet. So these are the important things, because being an allopath, I would suggest these 3 important measures, as well as stay active. And for rest, I am just not in favor of hormone replacement therapy. So we have got good plant-based estrogens, as treatment for such age group, fluvoxanates. So we can definitely suggest them, and they will cause improvement in symptoms.
Excellent. Excellent points, all of them. And I will reiterate, because this is the one I give in my practice also, your point on physical activity. Besides the calcium supplementing either through high calcium foods, I'm more in favor of that myself. That would be good. And the other one is to do weight-bearing exercises. Obviously, start slowly and go up. If you've not exercised through the previous decades, then build up. But if you have been somebody who's been exercising and workout, ensure that you do something called weight-bearing exercises, because that induces bone formation. So that is something to take care of that. I'll come to you, Dr. Rajesh, and then in closing, if I have any more questions, I'll tackle them. But let me just have you continue a little bit in, whether we call it UTI or irritable bladder or sometimes incontinence. Patients will describe to you, I can't control my urine. It came out. So what do you say, and how do you start, and how do you help them?
This topic of bladder and female bladder dysfunction, I think, all our panelists and my sort of esteemed colleagues here, we've all touched upon a few things, which is lifestyle. and lifestyle will affect. So, if you have like things like IBS or an irritable bowel or constipation, these are all kind of overlapping sort of risk factors for infection and bladder dysfunction as well. And it's all part of the same thing of lifestyle issues: being active, keeping your pelvic floor muscles working, making sure you hydrate yourself well, good balanced diet. They all have their positive effects on bladder as well as it does on bowel and other bits. Hydration, very important. We tend to think we drink a lot, but if you take a 2-liter bottle every morning, fill it up, you will find it challenging to finish by the end of the day. So 2 liters is really difficult to drink. I know some people do it, not everybody. The important thing about post-menopausal women and infections. Now, Dr. Neha and yourself mentioned about HRT, and it's sort of, trying to avoid it. But estrogen ointment being applied into the urethral area or the vaginal area, it has a theoretical risk, but no clinically evident risk of cancer. Especially if the women have not got a history of breast cancer, it can be used safely. So that's another adjunct to treating infections, treating issues with urethral pain, even sort of pain on sexual activity, because it makes the vagina supple again, it makes it moist again. Over treatment can cause excessive moisture, so you have to use it literally sort of for a couple of weeks regularly and then as and when needed. But it's the first line defense for infections. So you can stop using antibiotics all the time and just treat it without antibiotics. Similarly, there are other things like chemicals. I don't have time, so I will just quickly mention. There is a protein layer inside the bladder, which is the main defense of our bladder from infections. As infection or inflammation happens, that becomes patchy or ulcerated. So it's called GAG layer, glycoaminoglycans. If that becomes patchy, infections become faster. So if you don't want antibiotics, treating bladder with a weekly putting chemical through a tiny catheter, normally done by urologists or gynecologists, that can help as well. So you don't have to purely rely on antibiotics, especially where antibiotics have already failed. Those things can. But I know we are running out of time. I think UTIs and incontinence is a chapter of its own.
A webinar of its own. Yeah, absolutely. Great. I've had some learning myself. I know that as physicians, all of us, I speak for all of us, I think that the fun part of our jobs is that we are always continue to learn. There's no way for any one of us to keep up with all the research and all the new things that keep coming, happening, world across. And so for us as well, I'd like to say that thank you so much as a general physician, who needs to keep an eye on so many things going on. I rely on the counsel and then the advice to my patients from all of you, when I reach a level. But certainly, I hope that the people who joined us for the webinar have got something out of it for giving us that 1 hour. I certainly have. And I thank you all for giving your time and such wonderful inputs, which was simple, which people can follow, and hopefully focus more on preventing some of their issues than getting into complicated treatments. And then if you are at a point where you need help, if it's something that we can solve with a video consult, we're happy to. And if it's something that requires for you to be seen physically in person, then I trust that each one of us will let you know that this can no longer be managed on a video call. So with that, thank you to all my panelists, Dr. Mona, Dr. Neha, Dr. Rajesh, Dr. Manish, all of Dr. Ginny at the back end, and thank you to all the people who joined the webinar. Stay safe, stay warm, stay healthy, and get the vaccine soon if you're eligible.
Thank you, Dr. Rachna. Pleasure.
Thank you. Thank you. Pleasure.